Organising the webinar for you today. So we're going to kick off. It's started at 7:30 on the dot, so we're going to start off with the acknowledgement of country. And the RSCGP would like to acknowledge the traditional owners of the land on which this event is being broadcast, and we pay our respects to the elders past and present. And we're based in Melbourne, the RSCGP office on Wurundjeri land of the Kulin Nation, and we are right across the road from Yarra Park, which holds the MCG, and it's a very famous traditional meeting place for Aboriginal people. So I always like to make that point at the start of a acknowledgement of country, just that it's a very important, powerful place across the road, so it's good to be close by. So we're just going to go through some technical issues, if you have any. So this is the control panel. If you need to have any engagement with us, or you got any issues with your audio, this is where you access it, the little orange square, orange rectangle. Most participants use the microphone and speakers, but if you have any issues with the microphone, your internet server or anything, you can also dial up on the phone. And if you click the use telephone, that'll bring up the phone number to call, and then there's a specific PIN number to use so that you can access the audio via a telephone should your internet be not functioning very well and you're missing or having any lag time. That's how you can address that one. Everyone should be on mute anyway, and I've had a look and everyone is on mute, so this shouldn't be an issue. But if for any reason you come unmuted, you can mute yourself there with the little button there. And if you have any questions or comments, there's a question box, so that's where we'll be fielding. I see a few people have already posed some questions, which is great. That's where we'll be fielding questions, and some will be responded to, some will be upcoming, like the response will be coming up in the slide, and others will be maybe off topic, so we'll respond to some after. We have 200 people registered. I'm not sure exactly how many will attend, but probably close to 100. So with that in mind, there'll be quite a bit of traffic. So if we take time getting to your question, don't concern yourself, we'll get to it. And if slightly off topic, we'll move to it the next time. We've got questions, there's a chat box, so we might communicate with you via the chat box and provide you with some links. We'll do a poll during the webinar. There'll be 3 polls come up. There's a survey at the end, just quickly to complete your QI-CPD requirements. You need to complete the survey. We've got a couple of handouts that'll be provided that are just journal articles that are relevant, and then there'll be links to various websites and stuff come up in your chat box. And this is a number for technical support, sorry. But this is like their standard, support number. So you might get called up in a, select A, B, C, or 1, 2, 3. So I would suggest if you get cut off or anything, just call this number here, and at least you can listen in, because that's the most important thing. The slides and everything are good, but the most important thing is that you can hear. And now I'm going to hand over to the 2 presenters, and I'll let them introduce themselves. Thanks, guys. Enjoy the webinar.
Thank you very much, David. So I'm Tim Senior. Tim and myself and Chris are joining from Dharawal land this evening. So I'm a GP working at the Aboriginal Medical Service in Campbelltown, been there for 12 years now. And I also work as the medical advisor in RACGP Aboriginal and Torres Strait Islander Health. And I'm going to introduce you to Chris Carriage, who is effectively my boss at Dharawal. Good evening, Chris. So tell us a bit about yourself.
Hi, I'm Chris Carriage. I work at the School of Medicine at Western Sydney University. I run or coordinate the Indigenous programs across the 5 years of the curriculum, and we actually put a lot of our medical students into Aboriginal Medical Service for 5 weeks placement at the end of their 5th year of their course. I'm a director on the board of director at Dharawal and a director on the LHD. So, yep, thanks.
Excellent. So some of you, in fact, may take the Western Sydney medical students. So if that's so, then thank you very much. As David said, there is a small number of QI and CPD points available from tonight, and if you do the do the evaluation at the end, then you'll get the points. I want to start off with a poll just asking you what percentage of your patients identify as Aboriginal or Torres Strait Islander. And so if you fill out the button on there, click the relevant button, and we'll be able to see the results in a few minutes. It should be quite easy, so click the button now. We'll give you about 30 seconds to do that.
They give instant results.
Yeah.
They can hear us.
I'm just seeing the results come through there. 87% of you have voted, so getting up to 90%. Last few seconds. And we should be able to share the results of the poll with you. There we go. So those are the results of the poll. So 40% of you say you've got less than 5% Aboriginal Torres Strait Islander patients, and another 29% of you say you've got about 5 to 20, that there's a measurable minority of patients in your practice. And there's a few of you, about 10% each, who have significant numbers of Aboriginal and Torres Strait Islander patients. Chris, what are your observations on that?
Yeah, no, I'm just sorry. I was looking at the last two, which I think is, yeah.
Because it's interesting to wonder whether those are the actual numbers or whether it's an issue of identifying patients correctly, and because of course the identification of patients is crucial if we're going to do Aboriginal health assessments. Then we need to know who our Aboriginal and Torres Strait Islander patients are. One of the common things that comes up in Aboriginal and Torres Strait Islander health and with their patients are what we call, in a rather jargon-infested way, the social and cultural determinants of health, that are, I think of as things that are beyond our consultations, that have an effect on people's health. And so often we find ourselves giving advice and information to people, and people looking back at us and saying that there's factors out in the communities that they live in that prevent these things from happening. Chris, what strikes you about what we call the social and cultural determinants? Do they seem real to people? Do they? What are the most important ones that you think?
I guess
you see there?
I think one of the things too is like know your community. I think because I think we kind of like go where, I mean, I guess where you are is where it's important. So if you've got a population where being Aboriginal is quite obvious, and then you can identify, where people are in urban areas sometimes don't, who just, come in and out, and there's lots of different other groups. I think that thing about asking about like the identity of someone, is saying, are you Aboriginal or Torres Strait Islander? Sometimes I think a lot of people have it on forms. A lot of organisations have it on forms now. But yeah, go.
Yeah. So I think, and often these are big themes, but they come down very much to particular things that we may or may not be able to do. It's possible to feel powerless about it, but sometimes an issue of racism isn't something we can solve, but we can make sure that people don't experience racism in our own practices. Housing is a difficult issue to solve, but we are involved in advocating for people in the way that we fill out housing forms very often. The experience in the criminal justice system is again a difficult problem to solve, but there's actually a new system being trialled in various areas called the Health Justice and the Health Justice Network, who look at co-locating health services and legal services because it's well recognised that that's a powerful determinant of health for people. And then health choices is an important one, because often people want to make particular choices, but there are circumstances that mean that they're not able to make those choices, or they don't feel that they have the ability to make those choices. So for example, I can recommend healthy eating, but if healthy food is unaffordable, that's going to be advice that doesn't really help very much. And just an example from Sydney, they did a survey a few years ago that showed that the cheapest fresh fruit and vegetables in Sydney were in the eastern suburbs and North Shore, and which is where the better off suburbs of Sydney, and the most expensive fresh fruit and vegetables were in Aids in Campbelltown, exactly where our medical service is. So there's real difficulties in making those choices sometimes.
I was going to say, and just looking at the stuff like around that, the things around like, you know, even interacting with government services and those fears that come with that, I think people, you need to, that sort of like, it's real, it's quite, it's that thing around that factor of, like, I think they call it like the shame factor, where they can't, you know, they don't want to be embarrassed because they don't understand the language, they don't understand the system, they don't understand how that interaction with people, and I think that's a real fear. I've seen that in action quite a lot as well.
And so sometimes guiding people around the complex health system. We've got a few questions coming through about identification, and someone's asking, do you think there's value in breaking this down further and asking if patients know their specific people areas of origin? Often people will know that, wouldn't you say, Chris?
Yes.
It's often a really good question that shows you know more than just whether someone is Aboriginal or Torres Strait Islander, is that you know that Australia was a land, and still is a land, of many countries, and it's only since Europeans came in that we give a single name of Aboriginal and Torres Strait Islanders to that bunch of countries. So people would be a Wabakal, Wiradjuri, Aranda, and so that could be would you say that's a thing that can help engage?
I think just asking the question basically, are you Aboriginal, are you Torres Strait Islander, which is two different groups. You can't put it into both groups. Can I give a story about something? This is a personal story. There's something, my husband, who is not Aboriginal, he goes to the Federal Medical Service, and even they ask the question around, are you Aboriginal and Torres Strait Islander? So, or are you Aboriginal, are you Torres Strait Islander? And he was, of course, said no. But the thing is that identification straight up tells people how then their service delivery will be to that person as well. So, yeah.
And that goes to the comment that someone else has made about you can't tell just by looking at someone. And that's a really important point being made there. So if we look at the next slide, this is it possible, I always set myself a challenge of teaching, is it possible to teach Medicare in an interesting way? I haven't found a way of doing it yet. Item 715 is the Medicare Benefits Schedule item number for an Aboriginal and Torres Strait Islander health assessment. And essentially there are three types of health assessment that can be done under the single item number. One is a child, one is an adult, and one is an older person. And for an Aboriginal Torres Strait Islander person, that's over 55. And so these are the things that Medicare require of us to actually perform, to be able to build the health assessment. And so essentially it's gathering the information and recording the information, and then providing advice to the patient about ways of staying healthy. And those are sort of the most important bits. So again, we've got a poll coming up next. What proportion of your Aboriginal patients receive a health assessment each year? It'll be interesting to see what that is, and you can see the results coming through now. We get the advantage of seeing the numbers hop up and down as you press your buttons, and we'll share the result of that shortly. So 79% voted, press your buttons. We're up to 82%. There's another few of you needing to vote. So there we go, that's 87% of you voted, and the results of that show, probably not surprising, so about, it's split reasonably evenly between very few, some, and quite a few, and with a quarter of you managing the majority of Aboriginal patients getting a health assessment, though as you'd probably expect, there's not many people managing to do all of them. And that speaks to the way we identify and then the systematic approach that we have in practice, and is very interesting, and it might be worth, as we go through, just thinking how those numbers might be improved in practice if that's something we want to do. I think the next slide shows us the evidence base for what interventions are the most effective. So this is the National Guide to Preventive Health Assessment for Aboriginal and Torres Strait Islander people. It's a joint publication between the RACGP and NACCHO, which is the National Aboriginal Community Controlled Health Organisation. And this is the recommendations for what works for preventive health in Aboriginal and Torres Strait Islander people. So essentially the item 715 is what you can bill, but this is what works as part of that health assessment. We're writing a new edition of this right now, so watch this space for any changes. That will be out hopefully end of this year, early next year, and there may be some changes to that, so keep your ears to the ground for what's going to happen with the new edition of that. This is similar to the other guide that we have, which most people know and is very well known, which is the Guidelines of Preventive Activities in General Practice, or the Red Book, which, as this graphic shows, is 25 years old, over 25 years old. So that's pretty well known. And where the National Guide doesn't make a recommendation, the Red Book will be what to draw on, and again, as the evidence base for prevention in Aboriginal and Torres Strait Islander health. So, and I think people are familiar with that. This next slide has two sections. On the left, again, is so the Department of Human Services are the people who essentially the government department that is the custodians of Medicare and Medicare billing. And so they've created this flow chart about how Aboriginal and Torres Strait Islander health assessment should work. And I don't know about you, but I look at flow charts like that and go, ugh. And essentially the idea is about doing a health assessment and the GP doing it in conjunction with an Aboriginal health worker and or a practice nurse. And then once the health assessment has been done, that opens up eligibility for follow-up items to be billed through Medicare, including allied health. So we'll go into a little bit more detail about that shortly. But one of the most useful things about an Aboriginal health assessment is that it allows access to allied health referrals that wouldn't be available otherwise. So for people without a chronic disease, that allows you access to allied health referrals. For people with a chronic disease, it allows you access to 5 through a GP management plan and team care arrangement, and then another 5 through the Aboriginal health assessment. On the right side of the diagram are figures from the Department of Prime Minister and Cabinet that show from about 2010 the number of Aboriginal health assessments started taking off across all the age groups, and particularly for older Aboriginal and Torres Strait Islander people. The interesting thing about those figures is that while those have, while the numbers of health assessments have gone up, what not shown on that chart is that the number of follow-up items still remains quite low. So so while the health assessments are being done, the follow-up of them from the figures that we have through Medicare, it isn't that high. But that's going to be the crucial part to actually improving the health of people is what you do about the problems that you found in the health assessment. Would that be your observation, Chris? Sorry, would that be that the number of health assessments are going up, but the follow-up items don't get done?
Definitely. I think we even at Tharawal, there's a yes, our assessments are going up, but the follow-up from it doesn't happen as quick as we would like, or things like that. I agree. I think there needs to be a better strategy around it from service providers, and we haven't spoke about it any further than that. So.
And so the next slide talks about follow-up, and and so there's a few things. One is that there's a nurse item number, 10987, that means that following the health assessment, interventions can be given by an Aboriginal health worker or Aboriginal health practitioner or a nurse practitioner or practice nurse can bill on the GP's behalf. It's actually the GP's doing the billing, an item 10987, which allows a little bit of income for the practice for the nurse to do, nurse or health worker to do follow-up items as a result of the of having a health assessment. And so you can see on the screen there the items from the that are required in those follow-up items. And the next slide shows that the 10987 item can actually be billed in conjunction with other practice nurse items such as the immunisation practice nurse item, wound management if that's something that turns out to be there, and also the follow-up items from the chronic disease management item numbers if that's for someone who has chronic disease as well. So so that gives you extra item numbers to actually generate a little bit of income for the practice from the follow-up. So these are the allied health item numbers that come through that you can refer for. Now you don't necessarily need to know these item numbers. The important thing is that those are the allied health practitioners that you can refer to as a result of doing an Aboriginal health assessment. And so it gives you access to 5 allied health assessments from an Aboriginal health assessment. Those are the same set of allied health people as you see from the in the chronic disease management items. So next up is a poll where we're asking you what the major barriers are to follow-up, if that's been one of the main problems. What's, from your point of view in your practice, what is it that stops effective follow-up happening after an Aboriginal health assessment? While you're answering those questions, I'll just look through some of the questions that you've done. So someone's asking, do you think GPs are actually following up on action points from 715 but forget or don't claim the 10987? I suspect that's true. There was, we were involved in some research, the Canyini Vascular Collaboration. One of their early bits of research was a paper notes audit where they demonstrated that the actual claiming of 715 health assessments was very low, but the actual provision of preventive care was very high. And so I suspect there is quite a lot of care that happens that doesn't get measured by those statistics because it doesn't get claimed. And I think being aware of the item numbers and being able to claim them just actually helps those things happen. There's someone's asking, just to confirm, an Aboriginal patient without a chronic disease who has a health assessment can get 5 allied health referrals. But if they get a chronic disease, they get 5 allied health referrals through the Aboriginal health assessment and 5 allied health referrals if they have a GP management plan and team care arrangement in place. So that gets you access to 10. And someone else is asking, does this include INRs? Now, that's a good question, actually. I'm not sure. We might get that question on notice. If it's for the nurse taking the blood for an INR, I have to go back to what the requirements were for 10987, and you might examinations, interventions regarding as indicated by the health assessment, checks on clinical progress and service access, education, monitoring and counselling activities and lifestyle advice, prevention advice of chronic conditions and associated follow-up. You could argue, I suspect, that INRs would be covered by that sort of thing. I don't regard that as official advice, but I think there's an argument that could be made that taking an INR would be involved. So here's the result of the poll, and let's see what we have there. It's fairly evenly spread across all the items there, and I think would that be your observation, Chris, that that's fairly accurate?
That is actually, yeah. That's really, yeah.
And some of those are quite simple about, well, transport could be a potentially quite simple problem to solve, and I know many Aboriginal medical services, including where we work, provide transport for people, and it makes such a big difference. Something as simple, but that can be difficult to access at times. There's certainly lack of available services in many parts of Australia that many of you will be from today. That is a really tricky problem to solve if the services just aren't there. And then nearly half say community engagement and relationship with the practice. And that's, anything you'd say about that, Chris?
I think that's really important. I think if you create a place where Aboriginal people feel safe and confident in coming in, you've opened up the door, you're halfway there basically. Right. So if you keep getting them to come back to your service, and then I think that's what one of the key is to doing that.
Yeah. So. Yeah. So that's very interesting. And if we think about that and look at the next slide, one of the things that I'm really aware of is that everyone online will be in a different practice. And so having a think about what sort of strategies might work in your local area and your local community. And I think if there's anything that GPs are, it's people who are embedded in their local communities for the most part. The slide that you're seeing now invites us to think about those barriers and our solutions to them across a range of levels. And this is taken from one of the a journal article recently, which was about barriers to follow-up, and they took like a sort of sociological analysis of it and broke it down into those different levels. David's just posted a link to that article in the MJA in your chat box now. And so if we think about things happening across all of those levels, so things that are happening for individual patients and our interactions with them, particularly in our consultations. There's interpersonal level about the way that people interact with ourselves and our practice staff. There's the whole health service, our health service and hospital health services, things that are happening in the community, and then policies that have, that's a big word, but has impacts on things that happen in our surgeries. And I think we're going to look at each one of those a bit more individually. So these are some of the things taken directly from that paper, and as ever in an academic paper, they use quite big sentences, develop locally relevant evidence-based approaches to create community demand for follow-up health assessments. So Chris, how can we, and I'd be curious to see if anyone has any examples online of how you create community demand for follow-up health assessments, because I think there's community demand for health assessments, but for people to come back and say, actually, we've detected these problems, how can you help me solve these now?
I don't think you can, honestly. I think that's a really long-winded statement, sorry. But
no, that's fine.
and I can, relevant evidence base, I mean, yes, I think you need to, I mean, that's the thing about knowing your community, of course, and what's happening and all that sort of stuff, but yeah, no, anyway.
And I think because some of the things that we'll be looking at later as well are about our practice systems that invite people back in, and those only work if people feel that they trust the practice and that we're a good place to come back to, so that their experience in our practices was a good one. And I think if that doesn't happen, then people will always be reluctant to come back. Strengthen connections between health services and local communities to enable recall of patients who require follow-up. And that was one of the things that came out in the poll of barriers, was those connections between practices and their communities. And again, in an Aboriginal medical service, often we have an advantage in that the links to community are very strong. Again, that varies around the country. So just looking at some of the comments coming through about that, someone's commented that we use incentives to come back and get results. Footy shirts are very popular. And certainly we've seen that happen in various services. Other incentives that you've seen work, Chris?
I think I think there was one that used to do like fruit baskets or like vouchers to fruit shops and stuff like that. But I think that for me, I think it's that stuff around how do we get people to be really interested in their health. I know that sounds really strange, but I think when you're just working with Aboriginal community and people, and there's that stuff around go to the doctor and they go, yeah, but what is that? And I think that's something that I think it's a challenge for everyone, and make it what is that button that pushes it? And I think there's lots of things where people will go to their health because of their children, you know, if they're working in the community, there's that sort of stuff as well. So I think that's more of a challenge than a solution.
I think that's right. I'm often aware that the sorts of language that we use can be quite alienating, where we're talking about HbA1cs and health and blood pressure and cholesterol, whereas actually people do want to be healthy. They don't want heart attacks and strokes, and they've often seen that happen. And so talking in terms of concrete outcomes like that and preventing those, because actually they stop people doing the things they need to do in their community and in their family. And they care about that in the way that they don't care about HbA1cs so much. Got a comment here, talk to the patients about why the health assessment was done at the start, and that may help or may give some indication as to whether the patient will return for follow-up. One of the early questions we had at the beginning, someone before we even started was asking about how we can improve, they used a word that often comes up in Aboriginal and Torres Strait Islander health, how we can improve compliance in follow-up. And I think it's a really important point is that understanding the reasons that people might not want to come back actually makes the problem of compliance disappear, because once we understand the reasons for that, it's no longer a compliance problem, it's a problem of being able to afford it, or a problem of transport, or a problem of having housing and Centrelink appointments to get to instead of our appointment, or any number of other problems, but it stops being a compliance problem. And I think understanding our patients like that is often really helpful. Another comment here, the follow-up care is talking about real team approach for coordinating patient-centered care, outreach recall based in patient and improved KPI. Is it management plan team approach maybe? Certainly at Tharawal, we've found that the way we've improved this recently has been focusing on the team rather than just on the doctor's billing. So that more regularly now people are seen by a health worker or a nurse before they reach the doctor. We've got other workers looking up to see what people are eligible for beforehand. We're actively recalling people for health assessments, actively recalling people after health assessments and for GP management plans and reviews, and that's a team approach. It's not just depending on the doctor, and that's been successful.
Yeah, I think it's also the system too, like our Communicare, not Communicare, is it Communicare?
Yep.
Yeah. I think there's tags and pop-ups that when people are, you know, that have multiple health issues, and I think our system actually grabs onto those as well and pops them up and turns it yellow, I do believe, I think.
Yeah, that's right.
Yeah, so there's also coatings in that way to so people know, oh, this is a chronic health issue.
I heard of one practice who put in a clinical item called umbrella for all of their patients with a chronic disease. So they could just search the term umbrella and they'd pull up every chronic disease patient. So you didn't have to do it by diagnosis. And so there's some innovative ways out there. Someone's commenting that sending SMS messages can help patients remember to come, and that's something we've been doing as well, and phone calls before appointments to remind them to come back. And I think sometimes we just tend to assume that people are good at operating their diaries and things, and that may not be the case when they've got so much else going on. So we move on to the next slide. Cultural awareness training. It's one of those phrases that is always guaranteed to come up. Have you experienced practices that don't seem to be culturally aware, Chris, and what's the effect of that?
It's not really, not really. I know that sounds strange, but I don't. It's not like. I mean, before hospitals started to become a bit more culturally aware and sensitive, there are some real horror stories have happened and people have been like left in emergency and stuff like that with serious health issues and heart problems and things like that. But I think that everyone is starting to like rally around this and starting to look at what does cultural awareness mean, what is that, does it actually, you know, it's, I guess it's that understanding people's culture, but understanding your own culture within that as well and what your own role is. But not at the past few weeks.
Yeah, okay. So I think there's a really interesting thing there about understanding our own cultures, and because actually our practices all have a particular culture which can be welcoming or not welcoming to people, and sometimes just sitting in the waiting room and seeing the way that people behave there and what their interactions are like can be a really interesting thing. The diagrams that we've got there on the left is all the different arrangements that we talk about that are essential for doing this well. So some of it's fairly concrete, like follow-up and referral, and identification and treatment. But in there, a word that springs out at me is trust. And I think it's one of the things that's really important is acknowledging that our profession was involved in stealing children and removing them, and has been involved in it historically and other things. And so I always imagine that for each patient coming in to see me, there's a grandma sat on their shoulder saying, you know what doctors did, don't you? Can you trust them? Can you trust this one? And so there's a sort of level of doubt there that means that we have to actively work to develop trust, so that in our behavior we're saying, I know about that, and yes, you can trust me, and I'm going to demonstrate it. I'm not like those people. And so actively working to develop trust is really important. And on the right, there's a diagram there about the linking of self and people as individuals, family, which is really important, and how the connections to family and early childhood development, and then connections to community, and this sense that I got early on at Tharawal that if one of us is sick, we're all sick, and that those things are really important, that people can't be dealt with just in isolation. And I guess the other thing that you add in there would be connection to country as well, and because that comes through really strongly. Is there?
That is true. It's connection to country, connection to belonging where we are.
Yeah.
I mean, creating a hub for people to join in and be part of that community, I think, is really part of well-being.
Yeah. And so there are just a few questions coming through. How do you measure cultural awareness? Any thoughts, Chris?
It's, I mean, if you want to measure it by people coming through the door, I guess that's a way of doing it. But I think it's that stuff of understanding or trying to understand people, but understanding, I guess, yeah, where you are in that point, I think is another part of that is too. I don't think you can ever really measure, and I think it's always changing and growing. I think it's always, it's fluent.
It's the $600 billion question, I think, because we don't really know. My feeling is that I'm the wrong person to measure it, and I think for our own practices, we actually probably need to hear from our Aboriginal patients about whether we're achieving that or not, and that other people can't tell us. And there's another important here, that the training itself is only one aspect, that we can't expect just to do the training and then we know it. It's actually about having ongoing relationships with people in our community, so that they feel that we're their practice and that they can comment to us and that we'll listen, and that they feel at home in our practice, like medical home in a sense. There is some research coming out to look for about called barometers, which are looking at organisational barometers of their actually racism, but encompasses cultural safety, I think, as well. One of the interesting things is actually about, probably for larger organisations, but probably relevant for general practice too, is about the diversity of employees at your practice. And as a monitor of that. And I think the ability to employ Aboriginal and Torres Strait Islander people in your practice is actually goes a really long way when people are seeing familiar faces.
I think it's about also someone who your patients can connect with as they walk in the door. I think in having a steady personal face at the front counter going, "Hi, how you going today?" is something that we try and it just makes it much more friendlier, familiar. It creates a safe environment. Person creates a trust, that relationship, and and people will come back for that more than anything.
Yeah. There's again some really important things here. You can someone's commenting, you can make your practice a culturally safe base by having Aboriginal arts, flags, etc. And I think that's true. Those symbols make people feel more comfortable, like as they look through the window. There's some interesting research from Mount Isa that shows, they asked Aboriginal people and they asked non-Indigenous people about what are the barriers to culturally safe health service, and the non-Indigenous people said we need procedures and policies, we need artwork, we need paintings, we need posters, we need pamphlets. And the Aboriginal people said, yeah, that's all very well, but we want a relationship with someone in the service. If we don't have that, then all of those artworks and things don't count for anything. So they're probably necessary but not sufficient. In fact, and so I always imagine having a service where all of our patients can name a person in the service that they have a relationship with. And again, that goes to that idea that it's patients who will tell us whether we're culturally safe or not. Whether the patient sees the service as culturally safe. Someone's commenting on that there. So if we move on to the next slide. The other thing, just finally on that slide, Chris mentioned about what happens when people first walk through the door. You can run a beautifully friendly consultation as much as you want, but if you've been harangued by the receptionist, they won't make it to you. And so making sure that your practice manager, your practice nurse, your receptionists are able to make the practice welcoming, that enables you to do your best work. And as someone's pointing out, trust is earned, so the first impression is really important, especially for new patients to practice. People try you out. I know that people have come and seen me with something trivial, sore toe, to try out what the feel is, and then come back with something a little bit more serious, sore tummy, and then third visit or more, come back and ask me about what was really troubling all that time, just to see if they get the feel for whether I can be trusted or not. So those trivial complaints can actually be invitations to come back for the more serious stuff.
How long does it take for our new doctors to start getting patients?
So So I don't know if you heard that. Chris was just asking how long it takes our new doctors to feel trusted. That our registrars seem to do it very well, but for me it was about 18 months in the surgery before I felt I was trusted.
My new registrars are best advice.
And someone's pointing out we should employ secret shoppers to check out our practices. What a fabulous idea that is. Very good. Oh, Chris says he was a secret shopper, so that drives them around. The next slide is about what can be done at the health service level. Cost is a really important issue, that about the out-of-pocket costs for patients coming to see us, and particularly for patients going to see specialists that we refer to. The out-of-pocket costs for medication and the PBS CTG co-payment has gone a long way to really help with that, and particularly for things like sleep apnea machines or prosthetics or medical devices, where costs can be really difficult. So some of the things for practices such as the PIP Indigenous Health Incentive can offset costs for us, so that we can choose to bulk bill our patients, and using the follow-up MBS item numbers can make that more viable for our practices. Many PHNs have an Indigenous chronic disease program. Used to be the coordinated care and supplementary services, and they have some funds to help with out-of-pocket costs for seeing specialists, and some funds for costs for devices such as CPAP machines for sleep apnea, for orthotics for shoes from the podiatrist. And so that can be really useful. They also offer a bit of care coordination, so they can help with transport, they can help with coordinating the complex range of services that people need to attend. So that can be a really helpful service, and your local PHNs will be able to put you onto how to access that in your area. And then the third point is about the clinical information systems, so that we how we're using our clinical information and medical records to know our patients and to follow up our patients, and to use those for disease registers and recalling people at appropriate times. Again, that depends on having a practice system to do that, rather than just relying on individuals to put recalls in, but how recalls get followed up, who by, having someone responsible for that, and how they get completed and who by once they're done, and how they get followed up as to whether it's SMS or phone calls or letters, or and that each practice will work out how that works. Any thoughts on that, Chris?
No, sorry, Tim, I was reading the little...
Yeah, that's okay.
Thing, so I'm going, oh, okay. Yeah.
So just looking for other comments. So just from the previous one, someone's commented that the mentorship from an elder works well, and I think that's a really good point. Getting to know a local elder or a few local elders, and they can sort of mentor the practice if they're willing.
Yes.
Okay, and next slide. So, and this was touched on earlier, at the community level, raising awareness. My sense is it'd be interesting to hear if this is the case for all of you, that Aboriginal and Torres Strait Islander people know about health assessments now. They know about the Closing the Gap PBS subsidy program. And so we're getting more people coming in requesting a health assessment. And I know some services are, some Aboriginal medical services offer like health assessment days, where people come and do like rounds. They're based not in the clinic, but they're outside the clinic. Someone earlier was saying that someone had been offered vouchers for getting their health assessment, and that's I'm wondering where they came from, that they've been given gift vouchers. And again, that will be from a particular service. It's not a universal program, but many services will use will develop their own incentives for their own community. That might be a t-shirt, might be football, might be vouchers, might be a fruit and vegetable box, but many services offer that sort of thing as an incentive to have them done. And so that's good at raising awareness. But often, I suppose, the awareness doesn't come from the doctors themselves.
No, yeah, it comes from community. I mean, I think it's that stuff around, if there's always a key person in a community, I always find that person will encourage other people in their community to go and get their health checked or go and get something seen by the doctor, and to recommend a doctor's service as well. And Tim talks about that test parting, and I think for our service we went through a part where we had very low clients, and I think it was built from word to mouth when we started to build up our doctors and our health workers, and I think that's the stuff that needs that, I think that word and mouth and that key person in the community. And I think that's one of the hard things. If you've got someone in your organisation already, or in your service, in your practice, who's an Aboriginal person and they see you quite regularly, you could probably actually access their way of like saying, how do we get people in, and without putting too much responsibility onto them and stuff like that.
Yeah. So someone's asking, what are your tips for improving community engagement and community input into shaping and developing our health service? How would you go about
that? That is like a big...
Again, it's the $60 billion question, second time tonight. So yeah, your PhD is on this, Chris. That's true. So that might be a watch this space. I think it's probably going to be different in different areas, isn't it? Because everywhere is different, and so it'll be about meeting and chatting with the local elders in your community. There is a practice who published in the Australian Family Physician, and about, I think it was 2012, it was a January edition, about what they'd done as just a normal mainstream medical practice, setting up an Indigenous friendly health service. And the first thing they did was engage with the local elders, and they ended up doing it in partnership with the local university and what was then a Medicare local. And so it started from those initial conversations, and I think one of the things that struck them was that some of the things that the elders wanted weren't what they considered was needed, but they were able to set that up, and the elders had some influence about the structure of the service and the way it was done. And interesting, that had a knock-on effect to the rest of the practice. So they set up a specific Indigenous health clinic, which is where most of the patients went, but it made the surgery seem more friendly. So they actually had more Indigenous patients going to other doctors in the clinic at other times as well, outside that specific doctor and clinic times. So the knock-on effects of developing trust were quite profound, I think. And then I heard about a registrar who read that article and was placed in a practice in rural New South Wales for 6 months, and she thought that sounded good, and she actually set that up in her 6-month registrar placement in the practice she went to. So we can often make this sound really difficult, but actually going and chatting to people is often a way of making it happen and having a genuine conversation.
I agree.
Someone's commenting they don't like the word client, commonly used in AMS instead of patients. Yes, it may. Yes, I think that's going to be an ongoing discussion. I tend not to like the word client either, but I think I've learned not to lose too much sleep about it. We see people. Just looking through some other comments coming through. And just being patient about community engagement. It's not going to happen overnight. It's a long-term process. And that can be difficult. Developing that trust can take time, and time often isn't something that we feel we have a great deal of. And so that's one of those structural issues, I think. Also important to consider that the community is not going to be homogenous. There's going to be different groups in the community who want different things, and how to understand that. So so we've got time for any questions for you to put through in the question box. Any others? I'm just looking through those now to see what anything else that we've not covered in there. Chris, any comments or thoughts?
I think that is the thing that I always find interesting about engagement, and just to harness that stuff around building, I think, and as we said through this whole thing, is that building that relationship and trust. And if you already have Aboriginal people within your service now, your patients, is that you can build from them, because they're the ones that's going to have the word in mouth, and they're the ones that are going to talk to family, to friends, and go from there, I think. And as Tim says, to having a really great receptionist who's welcoming and inviting really can pave the way for more people to come into your service.
Sometimes there's the opportunity to use things like, so this is Reconciliation Week, and so knowing the sort of the holidays and festivals and celebrations, and so having celebrating National Reconciliation Week in a practice, celebrating NAIDOC Week with sort of specific posters or a morning tea or something, or inviting people to come into the practice or getting out of the practice. Some of those things can show a real intent that we're aware of those things. The other thing I'm aware of is understanding local histories. So I don't know all of your local histories, but I know in our area there's a particularly significant massacre which is commemorated each year, and is really important because it's a powerful shared memory that creates a lot of sadness in the community, doesn't it?
It does. I think it also, I know that sounds really horrible, but it's that thing around, it brings together not just the Aboriginal community, but also the wider community as a whole. Like our university goes there, people from the university go to the police, the councils, and other people who are interested in going there, and it kind of shows this, I don't know what you call that, like, engage in togetherness or that sort of stuff like that. So, but yeah.
Yeah. So knowing local history can be really important. There was an important point made earlier that I think is worth mentioning, that we may or may not have control over, and that's that often the drive for an Aboriginal health assessment is driven by the Medicare revenue that it generates, and same for GP management plans and team care arrangements, that we're almost hectored to do more of them for the Medicare revenue, and that can make us feel quite uncomfortable. And I think that's I think that's
because you think about it, it's like, having all these health assessments done for Aboriginal people, which is wonderful, but does it really change the health status of an Aboriginal person or the community as a whole? And how does that build upon closing the gap? And I think that we need to realise behind these numbers of people, and people, when they go to their health service, are looking for relationships and that trust with their GP and themselves. And I think that's a bit more deeper than that.
Yeah, and I think they're really useful in terms of getting access to allied health for people who need it. And I think that's useful. Aboriginal Medical Services have to report on their KPIs, and health assessments are one of those. PHNs also have to report on the number of health assessments done in their area. They have no levers to interact, to actually influence that, other than bringing you sandwiches and cajoling you. But so there's a lot of pressure in the system to do as many as possible, but they certainly don't work if we're not doing doing appropriate follow-up on them.
Yeah.
And I actually think one of the most useful aspects of a health assessment is the building of rapport, is saying, look, this is a comfortable place to be. We're not really an asset. That sort of rapport building assessment that you have to work at, and it doesn't work just by following a checklist on the computer screen. Yeah. Someone said, really useful, relationship first, health assessment later is my motto, and I think that's a good motto. Yeah. Patients know if they're there to be helped or if they're there to generate Medicare revenue for you. They can tell.
I think one of the frustrating things that I think we've come across with in our service is that we've had people who have gone to services outside our service who've had their self-assessment, and so we've gone to help them, and then nothing else has happened after it. And I think, and we've done all the follow-up at our service for those people, and I think that's a really sad reality of sometimes people who just, you know, that number sort of stuff. So
there's we're just running out of time. I do want, someone's just asked, someone's commented that working in a state paediatric emergency department makes the relationship really difficult. I agree. I think it's really hard in that setting. What is the evidence base that Aboriginal and Torres Strait Islander health assessments work and improve health? Actually, there isn't any, and the evidence
agree.
And the evidence. So it's a big policy push, but the evidence isn't there, and the evidence on health assessments in general population isn't there. I don't think that the policy pushes for us to do them, and that's really hard. And I think using them as a relationship development tool is what's and doing the follow-up is what's going to is what's going to make them work, if they're going to work at all. I think we're coming towards the end of time, and I'm sure many of you will want to get offline to see what's happening in the state of origin, to catch that. The irony does not escape us. Thank you very much for all your comments and questions. They've been very helpful, very enlightening. Thank you very much to Chris for joining me and doing the webinar. Thank you very much to David and to Diane for running the IT so smoothly and for helping it work. You will be getting the evaluation survey at the end. Please fill that in. It's the first time we've done this sort of thing in the faculty, and we'd love to know whether it's useful for you, if it worked, and if so, how we can do it better. So thank you very much. Have a good evening, everyone.
Is it done? Can you read some of this stuff?
All right, I'm going to stop the recording. Oh, so that means come up. Survey.
Yeah.
Let's read some of the comments.
Yeah. Oh. Hello?
Hello?
I'm here. Can you hear me?
Everyone hear us still?
Is that you, David?
Yeah, I can hear you.
Can the audience hear us?
Yeah, sounds like it. Yeah.
Hello?
Hello.
I'm just going to mute ourselves again.